I'd like to introduce Dr. Amita Gumidyala, and she can go ahead and share her slides at the moment. Dr. Gumidyala, I'm very excited to introduce. She's a clinical psychologist with niche expertise in GI psychology. Her skills and unique management options are really game changers in the care of patients with functional bowel conditions. So she'll be talking to us today about the brain-gut connection and perhaps what we can do about it. Dr. Gumidyala, thank you so much for joining us.
Thank you, Dr. Patel. Can you see my screen and hear me okay?
Yes, perfect.
All right. So thank you to all the course directors for organizing this event. Let me get this going in the slideshow mode. Okay, so like Dr. Patel mentioned, I am a clinical psychologist and I work here at the university in our GI department. And so that means I work pretty exclusively with our GI patients, many of whom have never worked with a GI specific psychologist. And I'm guessing many of the folks who are in the audience today probably have also not had a lot of experience working with a GI psychologist. So my hope really today is to just shed some light on what therapy could look like when you refer a patient over to GI psychology. Really quickly, I have no disclosures. And like I said, my goals for today really are to describe the biopsychosocial model in disorders of gut-brain interaction and to talk about a specific treatment modality, a pretty common one, cognitive behavioral therapy in GI psychology. And I'll end with a few case examples of that have utilized CBT, and we can discuss that hopefully during the panels after this section. So I know we see a lot of different kinds of patients in our GI clinics, but for the purposes of this talk, I'm really focusing on those functional GI disorders, or rather disorders of gut-brain interactions, as we refer to them now. So there's really been a push to move away from that term of functional disorders because it is so nonspecific and potentially stigmatizing to patients. And based on more recent scientific knowledge that proposes the interaction of the multifactorial pathophysiological factors involved in the development of these conditions, this revised term has been created and is used more frequently now. And so these DGBIs, these disorders of gut-brain interactions, are really classified by GI symptoms that are related to complex interactions among any of these following: motility disturbance, visceral hypersensitivity, altered immune functioning, altered gut microbiomes, and altered central nervous system processing as well. In terms of prevalence, DGBIs are incredibly common, found around the world. And in the US, it's estimated that at least 1 in 4 people have some DGBI. And in our GI clinics, really these conditions account for nearly 40% of the problems that are presented. And about 6 to 10% of that prevalence is with IBS, probably one of our most common conditions that we see. So DGBIs can affect any part of the GI tract, including the esophagus, stomach, bile duct, intestines. There are more than 20 different disorders that have been identified. And while they share physiological features in common, the relative contribution might differ by bodily location, duration of symptoms, across individuals, or even within individuals over time. And so this classification system is really great for categorizing and diagnosing these disorders. And it's a really good reminder that these are real disorders with very defined criteria. But in terms of effective management, it really requires a biopsychosocial approach that addresses that variability and complexity of patients who have these disorders. So when we take a look at this biopsychosocial model, I'm sure all of you are aware that these disorders, you can't just classify them as just medical or biological or just psychological. It's usually a combination of both of those things. But in this model here, what we can see is that there's a relationship between these early life factors, these environmental factors, that can influence an individual's psychological functioning, their brain functioning, as well as their gut physiology, and that mutual interaction. That's that brain-gut axis that we frequently talk about. And then these factors can influence that clinical presentation of the disorder, as well as the clinical outcome. And of course, the outcomes in themselves can in turn affect the severity of the disorder. But what I want to highlight here in this model is that these psychological factors, these processes, can play a pretty key role in contributing to the symptoms that patients experience through that brain-gut axis. And some of these factors that are listed here are things like GI-specific anxiety, hypervigilance, catastrophizing. These are things that we have been shown to contribute to more severe symptoms in our patients. But the upside is that these are also pretty modifiable factors through psychological interventions. And this is really what we're targeting in cognitive behavioral therapy. Another thing too that I'll mention is that even if these factors weren't the primary factors when symptoms first develop for patients, really over time, these things again like the anxiety, the preoccupation with some of these symptoms, they can start to escalate over time and become more problematic. And so, when we take a closer look at what cognitive behavioral therapy is, we can start to see how this happens over time. So the basic framework here, excuse me, suggests that thoughts, emotions, and behaviors are all connected and they all influence each other and can influence the physical symptoms as well as the brain-gut dysregulation. So if we take a quick example here, so say we have somebody who has IBS, diarrhea predominant. So, say they're getting ready for work in the morning, they've got a big meeting at work at the end of the day, and they start to notice that there are some mild GI symptoms. So they might notice some bloating or some cramping, and that GI discomfort that they're experiencing can lead to some of the unhelpful thoughts in that moment. So they might start to have worries about what could happen if their symptoms worsen. They might have worries about, what if I have to run out during the meeting? Even worse, what if I can't make it to the bathroom in time and have an accident? And so, of course, you can imagine that kicks up their anxiety a little bit more too, which in turn may contribute to unhelpful coping behaviors. So things like, skipping meals before the meeting, overusing antidiarrheal medications, maybe even trying to avoid those meetings or cancel the meeting altogether. But all of these things, heightened anxiety, the unhelpful thoughts, these can really amplify the perception of those symptoms in the brain, which of course can worsen the severity of the symptoms being experienced, and in turn can feed right back into those unhelpful thoughts, more negative emotions, and more maladaptive behaviors. So a lot of times, and I'll pull this out in session with patients, to elicit their own examples, and patients will frequently be able to point out examples where this is exactly what's been happening for them, and they've noticed that over time those GI symptoms actually start to worsen. And so a lot of times patients who find themselves in this sort of cycle can feel really helpless, and they might not know how exactly to break out of it. But in looking at this in this model, you can also probably see that there are several potential points of intervention here through use of cognitive and behavioral strategies to help address some of those issues that do come up. So in terms of the major components of cognitive behavioral therapy, or CBT, many of you might be familiar with these different components. So things like psychoeducation, relaxation training, cognitive restructuring, expanding on coping skills and behavioral experiments. But within GI psychology, the the goal here is that we're using these same strategies, but we're really tailoring them to help address the GI specific concerns that our patients are dealing with. So a quick note on that, just in terms of, who I end up seeing in our GI clinic, really, the top group highlighted in green over here, those folks who make it to, or who are good referrals to GI psychology are those folks who have pretty severe symptoms. They endorse having their quality of life being impacted by their GI symptoms. They might have high scores on measures of psychiatric distress. They also have pretty good insight into things that are contributing to their condition, and they're motivated for treatment. They're motivated for some of the behavioral changes that they might need to make in order to help get a better control over their condition. And this isn't to say that, those folks who have other issues, they might be better suited for more general psychology. But if their bowel condition or their bowel symptoms start to worsen, those patients could also come back and see us in GI psychology. And then, of course, those folks who have more complex psychiatric conditions, we usually encourage them to establish care with more general mental health providers or other psychiatric providers to stabilize their mood before they come work on GI psychology. And then also really quickly, I'll just mention a quick note about the efficacy of CBT. So CBT is an effective treatment. So this is a treatment modality that has been most extensively studied of all of the brain-gut psychotherapies. There are more than 20 randomized controlled trials of CBT for IBS in particular. And we also see that 60 to 70% of patients with IBS are treatment responders, meaning that they had greater than 50% improvement in reported symptoms of either pain or altered bowel habits. We also see that CBT can be effectively delivered by different providers across different modalities. And the number needed to treat is 4, which is pretty impressive considering that drug therapies are typically in the range of 7 to 10. And also in terms of durability of the benefits, there are estimates between 8 months to 2 years that patients do pretty well for a long period of time after engaging in CBT. We also know that it can be an effective treatment in treating other DGBIs, things like functional dyspepsia, non-cardiac chest pain, and really it can be customized for use with other GI conditions like IBD, for instance. So there's a lot of evidence supporting the use of CBT with our GI patients. So coming back to the components of CBT, so this is really getting at what am I doing in therapy with our patients. So the first part here is psychoeducation. So a lot of times our patients come in or they might not have an understanding of why they're being referred to a psychologist for their GI condition. Many have gotten the impression that it's all in their head, or they've been told, just to relax or exercise more to get their symptoms under control. So this is a really good opportunity to provide education on the clearly defined condition that they've been diagnosed with and the development of their condition, that it really is multifactorial, and even that the factors that played a role in onset might be different from those that are maintaining their symptoms. So oftentimes I might even pull up, the definition or the formal criteria for the different conditions. So just as an example for IBS, I might pull this out and show the patient, this is what the criteria are, and what you're saying suggests that you meet criteria for this particular condition. So again, it helps set the stage for having a better understanding of the condition that they're experiencing. And it can also help set the stage for why psychological treatments might be useful in treating their condition. So in particular, when we talk about the brain-gut axis, I frequently hand this out to providers as a reference, but finding a way to talk about that brain-gut axis in lay language to help patients understand that, you know, there is this communication that happens between the brain and the gut, and sometimes it's disrupted. And when that happens, for any reason, the brain perceives sensations from the gut more strongly and might start sending inappropriate signals down to the gut that disturbs intestinal functioning. So again, just, you know, setting the stage for why psychological treatments might be useful for the patient. It's also helpful to talk a little bit about the role of stress in symptom presentation. And I really like to stress that this is not the only reason for why they're experiencing the symptoms that they are, but it's one of the things that could be contributing to their symptoms. And then lastly, managing expectations. So helping patients understand what to expect from treatment. Again, they might have had a lot of negative experiences in trying to address their concerns previously. A lot of times patients come to me as a last ditch effort. And so, you know, the thought is, well, if this doesn't work, there's nothing really left. So we can really help provide some clarification on what it is to have a successful treatment. And I really try to help shift that focus from, you know, completely resolving all of their symptoms to being able to manage it well enough so that it doesn't interfere with their daily functioning or their daily activities. So really the emphasis is on improving quality of life. So another huge component of CBT is relaxation training. And really here, the goal of relaxation training is to help learn how to reduce that physiological arousal. So oftentimes I'll start off by talking about this in the context of sympathetic nervous system arousal, or that fight or flight response that happens in response to any perceived threat or stressor. And I talk about some of the physiological changes that occur in that moment. So things like increased heart rate, increased sweating, blood pressure increasing, change in respiration, all of those things. And I lead patients through different relaxation exercises to help show what it is to engage in the parasympathetic nervous system response. So the rest and digest response rather than that fight or flight response. And really, you know, I think a lot of education around why this can be useful is very important. So again, it helps reduce that physiological arousal, can help reduce muscle tension, shift focus away from the GI symptoms, and even help them to differentiate between what it feels like to be really tense and what it feels like to be more in that relaxed state. And so there are a lot of different relaxation exercises that can be taught, but I really focus on diaphragmatic breathing with most of my patients because it is so easy to learn and implement. And really patients can do this sort of anywhere. I also often recommend some of these different apps. Insight Timer, Calm.com. Breathe to Relax is a pretty basic one that the VA and DoD developed, and it's really straightforward and just focused on breathing. But another GI psychologist, Dr. Megan Reel over at, in Michigan, has a nice demonstration of diaphragmatic breathing that I often refer patients to as well. So another huge component is cognitive restructuring. And really here I remind patients of that CBT model, how thoughts can negatively impact mood, behaviors, and can lead to increased symptom intensity. And again, what we know here is that our patients who are experiencing some of these DGBIs tend to have very specific thinking errors related to their symptoms. So for instance, they might engage in some catastrophizing, things like they're essentially predicting the worst possible outcome, the worst case scenario. They might be jumping to conclusions. So predicting negative outcomes of events that really aren't based on any facts. So a lot of times we talk about things like mind reading or fortune telling in this case. There's also all or nothing thinking or black or white thinking. So really either or seeing things in either or right or wrong, rather than really in terms of degrees. And so that's another cognitive distortion that we can address. And then lastly, overgeneralizing. And I should be clear that these are just a small list of thinking errors that patients often commit, but there is a larger list that I usually hand out to patients. But overgeneralizing, taking one or two bad events as an overall pattern, so drawing conclusions based on just a single event. So frequently we'll help engage patients in identifying those unhelpful thoughts. And so we'll have them complete some worksheets like this where they can start to see the connections between their thoughts, or among their thoughts, their feelings, physical symptoms, as well as how they react, how they respond, the behaviors. And so this is one way to help identify those patterns of thinking that can contribute to the symptom presentation. And then after they're getting good at recognizing when they're having those unhelpful thoughts, we start to work on modifying those unhelpful thoughts. And this is really done through Socratic questioning. So using things like evidence-based logic, things like asking themselves questions like, how certain are you that this will happen? How often has it actually happened in the past? Perspective taking, thinking about alternatives. And ultimately the goal is to help them modify that unhelpful thought in order to, again, affect the mood, behaviors, and the physical symptoms. And I really want to make it clear to patients that I'm not just talking about thinking positively. Rather, we're focused on having more helpful thoughts. So, if somebody is having a stomach ache and they're thinking, I can't go out tonight because my night's ruined, the modified thought doesn't have to be, well, everything's great. Rather, it'd be more helpful, right? So a more helpful thought might be, even though my stomach aches, I really enjoy spending time with my friends. So that is a more helpful thought because it's more likely to impact their mood in a positive way, but also in terms of behaviors are probably more like to engage in more adaptive behaviors. Coping skills, that's also part of cognitive behavioral therapy. And I'll just really quickly say here that coping skills sometimes, a lot of times patients will pull away from activities that are meaningful to them or important to them. So helping them return to some pleasant activities or enjoyable activities, problem solving around that to help them be able to do those activities might be a part of increasing their coping skills, or using more acceptance-based strategies. So in times where they're not able to have complete control over what's happening, engaging them in things like meditation or acceptance-based strategies. And then lastly, I'll just mention really quickly, things like exposure techniques. This is where we start with really mildly or moderately difficult exposures and progress to harder ones in order to help them address and overcome the fear and avoidance that they might be engaged in. So this is really similar to things that, to strategies that we use for patients who have phobias. So it's particularly useful for patients who engage in considerable avoidance of activities or situations. And then behavioral experiments, something that's used really frequently. So, having them test out their beliefs. So for instance, if they have the belief, I have an urge to go, or if I have an urge to go, I have to respond or I'll have an accident. You might encourage them to test that out. So try delaying a response to an urge. And oftentimes what patients end up seeing is that, they can urges subside or they have the capacity to wait. I realize that I am out of time here, so maybe I will just really quickly talk about this case example, one case example. So in this case, this is a woman who also had Crohn's, but has a diagnosis of IBS. diarrhea predominant, and was currently on Zofran and Ventol, which she didn't find very helpful. But some of the psychological factors that were coming up for her were that these symptoms interfered with her social life, chores, travel, and she also wanted support from her friends, but worried about how they'd see her. And symptoms had worsened, particularly during this pandemic when she was staying at home. So in thinking about CBT and the different components of it, what we focused on in treatment was first psychoeducation. So again, the role of stress in that brain-gut interaction. And then a lot of our sessions were really focused on cognitive restructuring. So she had a lot of thoughts about seeking support from her friends that weren't helpful. She also had unhelpful thoughts about traveling and going out to socialize if she was experiencing any of those symptoms. So we spent a lot of time practicing catching those unhelpful thoughts and working on modifying them. And then lastly, just because she was unable to go out and see her friends as frequently because of the pandemic, we also developed a plan to help her stay connected to her friends, to help her sort of beef up some of those coping skills. So maybe I'll stop there, but my quick take-home points are that CBT is an evidence-based treatment for IBS and shows promise for a lot of other DGBIs as well. And really the focus is very specific skills deficits that contribute to worsening GI symptoms.
Great, thank you so much, Dr. Gumidyala. I get the sense that your expertise could really occupy an entire day-long webinar, so thank you for sharing your expertise with us.